It's a real pleasure to be here. Thank you, Enrique, for this invitation. I'm so disappointed not to be there in Mexico City. It's a great honor to follow my good friend, mentor, and luminary, Len. Thank you so much for that fantastic discourse. We are overdue to write this up. These are core issues that gnaw at me for maybe 40 years. Thank you for bringing that together in such a coherent and cogent manner. And I'll answer the question that Len was answered as well later on. The question really is, how did we get here? And does it have to be this way without being Pollyannish, without being squeamish about these core problems? Because these are existential problems. They're not simple by any means. With that, I'm going to kick in and start my talk here. I'm having a problem with advancing my slides, but let me see what's going on here. So here's who I am as a brief background, as an anesthesiologist, as an intensive care physician. Been involved for about 25 years in running departments and hospitals and advising hospitals and organizations in the US and globally. In this talk today, I've been asked to talk about human factors, and particularly the word, care, human and human factors, and we'll talk about the alignment and the importance of those two terms. I have no meaningful disclosures to share relevant to my talk today. So I love this quote by Dr. Reles, this definition, what is care, human? I'm going to highlight the particular element, which is protect from harm, and talk a bit about that. I think Len covered very well the rest of this definition. And so I'm going to talk about what we mean by harm. And so in the last 50 years, we have lots of reports from high-income countries, low-income countries, including reports from Mexico suggesting that care is not as good as we think it is, that care can lead to harm. I'm not talking about lack of access to care. That's a separate type of harm. I'm talking about care that's delivered, but not delivered safely. I'm talking about care that's delivered, but without proper intention. I'm talking about care that's delivered that causes service harm, as Len discussed, that causes meaningful physical harm, that causes emotional harm, and causes deep physical and financial harm as well. We have lots of data. A few samples on the left is from North America, is from Boston. A good friend of mine, David Bates, showing that in the Harvard hospitals from the period of 2000 to 2023, almost a quarter of patients have measurable, preventable harm, right? So a quarter of care, remarkably, in fantastic hospitals. I trained in one of them for many years, and yet still a remarkable amount of what management would call, the business world, service failures. If the service is to deliver high quality, patient-centered, kind care, these are service failures, although here they just measured the physical harm. If you added that to all the kindness harm, to borrow a phrase from Len's discourse, then it's much, much more than a quarter. On the right is the largest study of its kind in Latin America. In this study, which looked at the complications after cancer surgery, and as you can see here, quite a bit of complications, 3 times as much in Latin America than in North America or in Europe. Here's another way of looking at this. This is Aradarzi's work from London, looking at, this is data that's published by ministries of health, so with all the problems that go along with that, but this is the forward-facing, outward-facing data. For the sake of the study, the United Kingdom is 0 on the scale, and you can see the range of variation from Norway on the right of this graphic, and on the left is Mexico. By choice, they chose Mexico, and you can see that the 2.6 units, which is equivalent to 3-fold, maybe 5-fold difference. So the outcomes in Norway versus Mexico, using the same technologies, with the same training modalities, more or less, with the same internet and the same AI, as a 3 to 5-fold difference as measured by common standard defines patient safety. Here's another way of looking at this. This is some work from a team I work with, looking at avoidable mortality. And as you can see from the right, in this case, West Virginia, so the various US states, the average of the US is marked there. And on the left side are all the European countries or OECD countries. And again, you can see on the left, the least amount of avoidable mortality would be Lithuania. Notice the massive variance across countries. And the key message from this slide is we could do better, that there's a massive amount of preventable harm that's been normalized. And again, we're talking about all types of harm, although in this case, we're talking about death. We're not including the trust harm, the kind harm, the types of harm that goes even further that Len alluded to. The Joint Commission, which is active in Mexico as it is in around the world, argues that the top 3 causes of harm to patients are human factors, leadership, and communication. And so if I was in the room with you and I would ask the question, I'd be delighted to hear your comments in the chat box. How many of you have had a formal training course in human factors? So maybe in the chat box, if you can mark it out. Typically, when I ask this question in North America as well as in Mexico, usually about 3 to 5 people out of 100 say yes. It's very, very uncommon. It's not part of requirements in medical schools, nursing schools, public health schools, management schools, either in Mexico or in the US. So an extraordinary gap in education and training, which helps to answer part of the question that was posed to Professor Berry before. Here's some work that we did 20 years ago now, looking at, this is the first ever study published on wrong side anesthesia blocks. I was very interested in this after we had an incident that I later on talked about when I was on the Oprah Winfrey show. And this is the first ever study on wrong side anesthesia blocks. Although I was not to have the first wrong block, there have been thousands of them, but nobody talked about it and nobody ever published on it until 2007. And in this study, we looked at the databases in North America, in Congress, in the states, and what we found is that most wrong side cases aren't reported to the Joint Commission, and in fact, they acknowledge that only about 4% are reported. Subsequently, we put forward that there are about 3,000 wrong side, wrong patient, wrong level surgeries in the US, and that's never been disputed. Other studies have reinforced our findings. Parenthetically, I'll note that the last available data, which is the full year, which is 2023, suggests that in the US, there's been a 26% increase in wrong site, wrong procedure, wrong patient, wrong implant surgeries, even when all of them are using surgical checklists. I'll come back to why checklists are a tool, but not a panacea. So another example, some work from Texas, looking at sponges left behind in patients over the last 7 years. This has been extensively reported by the Houston Chronicle. There's been no decrease in the number of things left behind in patients in Texas in the last 7 years. An extraordinary statement. And you can see there on the graphic the types of cases. They're much more common in thoracic and GI. The point, though, is that we're not learning. So maybe the question is not, why does this happen? The larger question is, how do we help healthcare systems learn more effectively? What does that mean for organizations like COFEPRIS in Mexico or CONAMED when they have to truly focus, what is the role of learning from adverse events? So for many, many years, I've been very interested in studying non-medical industries. I want to share a few thoughts about that. This is some work that I did with Don Berwick and Ram Liberty, again, about 21 years ago, in which we looked at how safe healthcare is as compared to other high-risk industries. And as you can see here, healthcare back then was so much more dangerous, but more importantly, as an anesthesiologist, I deliberately put this in, that inside the anesthesia space, which is considered to be the safer of all spaces in healthcare in general, there's a massive difference with the same people when they're dealing with an ASA1 patient versus an ASA3. There's a 1,000-fold difference in the same hospital by the same people. which is really quite dramatic. And this paper, which was a paper of the year by the Annals of Internal Medicine, led to a lot of conversations about why can't we learn from other industries about these domains. So what is human factors? Human factors in general is defined by this wheel on the right, including, as you can see, Len, it includes elements that you alluded to. So it includes how we treat people, how we think about the environment, the aesthetics, the stress, the trust, the moods. And of course, it also includes harder engineering things like the building, the alignment, the equipment. All these things are part of human factors. So when we think about care human, it's interesting that play on words of the human here. And what does that mean? Most data shows that both in Latin America, North America, and Europe, about 3/4 of adverse care is related to non-technical skills. Non-technical skills, often under the rubric of human factors. So this would include coordination, collaboration, truth-telling, trust building. All these so-called soft skills are not soft at all. They're harder skills. They're actually the hardest skills there are to train, much harder than technical skills to train, as it turns out. This is how aviation looks at it. They talk about software, hardware, liveware, environment. And so it's intriguing as we think about using this model that has been used to make aviation safe and nuclear power and manufacturing. How does it apply in a healthcare context? So I want to go back to the giant, the seminal giant of all manufacturing quality, which is Deming. And Deming, who was essentially a private consultant, who wrote extensively and was mostly ignored by a lot of industry in the US until MacArthur brought him to Japan. And in Japan, together with the Japanese world of Kaizen and the entire historical quality expertise in Japan, together came out with this model that he called the profound knowledge of improvement. And at the heart of it, to paraphrase Len, is the customer, always the center of the system. And I think, again, another rubric to answer the question that was asked is, we do not teach, Len, in medical school that the patient is the heart of the system. We don't. And so until we do that, and if we do that, we often do it in a very tokenistic, very paternalistic manner. Other elements of Deming, the system, the variation, the change management, the trusting of the frontline staff, which I think is part also of preventing burnout. I'll show you that data soon, is that if we don't trust the frontline staff, we allow management to control what goes on in the operating room, in the clinic, in the pediatric clinic, we often get workarounds, gamification of data, et cetera. Again, to quote Deming, use the chat box. How many of you in your hospitals or health systems, it says on the masthead that your goal is to improve health outcomes? Typically, less than 5 out of 100 in my talks will say that this is part of the mission statement or the value guidance of their board or executives. Another key person to understand here is Jens Rasmussen, a giant Dane. Denmark is in the news today. They've given so much more than some people would like to think. Jens Rasmussen is the single most important person in understanding safety of high-risk systems. And healthcare, as we heard, is a high-risk system. And what Jens argued over decades and decades of work, what was ignored, by the way, by healthcare in Denmark as well, is that the human is the most important part of the human-machine interaction. And unless we understand how the human interacts with the system, we're often going to make the system more brittle, more dangerous. And again, some of these elements I hope we can talk about is how AI, while offer great potential, is actually making the system more brittle, more vulnerable in many ways. A corollary of that work is Pascal Carrion's work from Wisconsin, that if you think about the work system on the left, in the middle is the processes, on the right is the outcomes. So as we think about the care human that Enrique has led on, how does that fit inside of a social technical model? Where does that fit into that work system? The culture, the attributes of the physical environment, the cognitive leadership, the social cultural setting, Len alluded to the psychological safety that I'll talk about, all that is directly correlated to better patient outcomes, better professional outcomes, and better organizational outcomes. To put it bluntly, care that's delivered well and respectful makes you more money. The data shows that very clearly, and I'm glad to talk about that in the Q&A as well. For many years, Paul Batalden, the godfather of IHI, and a close friend and mentor, and a PhD supervisor of my wife, and the godfather of my son, the work on clinical microsystems is putting the patient at the center of the organizational approach. This is based on the Tuck School. Jim Quinn, who was a professor of business at the Tuck School, who argued that all good businesses are based on microsystem-based approaches, so applied to healthcare. Why do we do what we do? Again, this is not taught in medical schools. So this is another rubric on why healthcare has still not really taken this to heart and truly transformed their education, their regulation, their oversight of health system providers. You're going to hear later on from Helen Haskell, and I'd be remiss not talking about the seminal work that she's done that's transformed the world of healthcare in her state in South Carolina, but also around the world. And her son tragically died because the staff were not clear about who's responsible for the work. They weren't transparent about their job. They lied. They didn't really respect the patient and Lewis's parents. Ultimately, that led to the first of its kind law in the world, where staff must wear name badges that states their hierarchy, and they must agree to call for help when a family says, we want somebody senior. Sadly, 15, 20 years later, some work that we've done in the UK called Martha's Rule. This young Martha, at the age of 12, died at King's Children's Hospital because the family said something's wrong, but the staff didn't listen. And she went on to die, and as of September, 4 months ago, all English hospitals have this new rule that says that if the patient member or the patient says, I need somebody senior and or I need somebody else, they must agree. They cannot put them down. They must listen to the patient, who obviously, and the family, who obviously has so much wisdom about their body, about the care, about the journey. So now briefly to Mexico. This is a project that I've been working on with a variety of team members, physicians and nurses and patients in Mexico. It's the largest cluster of adverse events in anesthesia in the world. Tragically, it's led to the death of dozens of people in Mexico and a few in the US, and hundreds of people that still suffer in Durango and Matamoros. So much of this work would not have happened without the leadership of patients and the community of family members that lost trust in the system. This is the report. So this is a fungal meningitis that was introduced via an epidural and spinal. This is the first patient in August 23rd, 2022, and ultimately, serious disability, and went on to die later on. This case, which we've done a lot of work on in Mexico, are in conversations with CONAMED, and hopefully we'll get some more support to gain access to the data. What it suggests very clearly was not listening to patients, not following national and international guidelines for sterility, and ultimately black market use medicines and medicines that were carried by doctors, because in Mexico, anesthesiologists must carry their narcotics for many private hospitals in their car, on their body, and so often that poses all kind of problems. As you can see here, this has led to
estoy escuchando una clase de México,
many injured people. And can we maybe turn Ivan off? Thank you. And ultimately has not just been in Mexico, but also in the US. And there are multiple studies that we've done on this, and still ongoing on how to help transform the Mexican perioperative system based on these cases that we still do not know exactly what was the causes of this terrible infection that led to 57 deaths, 115 infected people that still suffer, many of them. And again, I'm glad to answer questions about this fungal meningitis that happened 2+ years ago. Again, we've been interviewing patients in Mexico using these techniques to better understand through the lenses of the patient lens. We've asked them about trust and kindness, as well as what actually happened to them and their families as they went through this process. Unfortunately, in Mexico, as in many countries, they wanted to blame, so they found the CEO and they decided to put the CEO in jail for 24 years, but we still don't have the underlying causes. And so while it might feel good to put somebody responsible in jail, this does not solve the problem, which still remains a potential source of harm, both in Mexico and beyond. So let's talk about what I call the 8 C's: the culture, the context, the constituency, the core need for championship to change the system, another element we don't teach in medical school, the role and importance of collaborators and networks, how we communicate, the coordination between the layers, and of course, the credibility. I'm so delighted, Enrico and Raul, that you're doing this under the auspices of the National Academy of Medicine in Mexico. I think that that type of credibility is essential if we're going to get the professional societies and clinicians in Mexico and others to listen. So when we talk about culture, we talk about here's how we do things here. So we know that culture often is a source of adverse events. What does that mean specifically for patient safety? It means how do we design a culture where the values and beliefs are embedded in how we do what we do, where the number one goal is, under all circumstances, our goal is to prevent harm, even if we lose money, even if we don't want to do that, even if any other constraints. This must be the number one reason why we are in the business. And that means supporting patients, supporting the comments that Len spoke about, kindness and truth-telling and trust building throughout the process. James Reason, another mentor of mine who sadly passed away last year, seminal work on what does it mean to actually change the culture. James was a student of Jens Rasmussen, wrote a lot about how the organizational culture, when there are problems, the last thing that a clinician can do is just say nothing or keep your head down. And so that means being informed about these problems, reporting these things. In Mexico, as in the US, very few clinicians report adverse events. Our studies suggest that as little as 10%, sadly. So that means that when you read a report about adverse events, a good study, you're only often sampling a small part of the problem because of other issues of people being afraid to speak up, because people don't really learn, because they're afraid of the consequences. Len alluded to psychological safety. This is Amy Edmondson's work, a seminal work from Harvard Business School, now nearly 27 years old now, the foundational work. It took about 20 years to get into medicine, but the role and importance of staff feeling safe to speak up as a human factor. So the care human here would be taking care of the human staff members that need to be feel that they're safe to speak up. So I highly recommend her book, The Fearless Organization, again, not being taught in medical schools. This is some work that I've done in Norway with one of my PhD students. We've been studying for 10 years the likelihood that a patient will have harm in Norway, which, as I showed you, has one of the reportedly best outcomes in the world. The chance that you will die in a Norwegian hospital is directly correlated to how well the staff feel about their work and how much they feel respected by physicians and management. Or to put it differently, if you want to increase the mortality in your hospitals, disrespect your nurses. Don't listen to them, marginalize them, don't acknowledge their work, and they indirectly, not directly, they're not causing the harm, but the system inferences that that type of action towards them leads to harm. So this is the largest study of its kind, 2.5 million people, catchment area, half of Norway. Love to take questions about that and the implications around culture and outcomes. I've been interested in culture, particularly in surgery as an anesthesiologist and intensivist. This is some work that we did about 18 years ago, looking at the culture in pediatric cardiac surgery with live observers in and out of the OR. We did this in the US, we did this in the Netherlands, we did this in other places, and what we found was that 1/3 of the people in every big case feels that one of the team members is not ready for the case. Either they're too tired, or they're intoxicated with drugs, or they're simply not up to par technically or otherwise. 1/3 in the best systems in the US in this study. We further, and this is work that we did in North Carolina, we asked patients of children that have cardiac surgery how to better improve the respect, the kindness, and the trust of them. And what the family said to us, Len, was the key thing that got them to trust the system was when the parents were taught to help support the care of their child. By them allowing, and this is one of the many quotes that we took from these interviews, by the family feeling that the staff trust them in an incremental way to be part of the process, that helped them grow a lot more trust and support and overall good feeling about the care of their child, independent of how the outcomes of the child was. That's a very important statement. Independent of the outcomes was how the family felt the way they were being treated by the staff when the staff was taking care of their child. A lot of good interest in this in the UK. This is some work that we've done in Wales. One of my fellows, Chris Sube, now in Singapore, looking at this idea of the upside-down hospital. Again, another aspect that was asked before to Len, why is it not changing? Because we don't change hospital management practices. It's not really run this way. We don't really co-design with the input of patients. We don't really bring patients into the C-suite executive decision-making. They're not part of strategic planning, and more private equity that Len and I have spoken about drives so many of these decisions, and not the needs of the patient and the direct community in which the hospital is responsible for caring for. We've gone further. This is a very large study from Texas, from Methodist, 6,000 patients. In one arm, it was a natural surgical procedure, in this case, an elective knee surgery. On the other, we designed a tool, a digital tool with patients and families, and we asked them, Len, what type of technology would help you feel more trust, more support, more engagement? And after we designed this over 2 years, we then followed these patients, and we found 3 things. Number one, the patients felt better about the overall process by 28%. Number 2, the pain scores were down by 18%. Number 3, after 6 to 9 months, the readmissions to the hospital was down by 17%. In essence, by designing digital tools to enhance the elements that Len spoke about, kindness and trust and meaningful engagement, we got better flow, better service, better financial outcomes. So there is a clear correlation between the design of digital tools and enhancing outcomes by using the principles that Len spoke about. We've been mapping out processes in and around the OR for a long time, time motion studies, site layouts. We do this by observing teams, by working with patients and providers. This is the care human aspect of the staff and the patients participating in the design, doing process mapping, doing task analysis. These are things that often are not taught in medical schools, even today. We do not teach fundamental engineering of how to map a process. I love this study from a colleague of mine in North Carolina, in which he discovered that when he asked surgeons and anesthesiologists how often do they lie to each other and game the system because they don't want to face the bad news to each other. For example, a surgeon would, even though there's blood loss, will not say there's blood loss. An anesthesiologist will often not say if staff is available. And it turns out that about 1/4 to 1/5 of the time, staff lie to each other, not because they're bad, because the system undermines their ability to deliver a truthful answer. Again, we do not teach this in medical schools. We don't train nurses, anesthesiologists, and surgeons together, and so we expect them to work together, but of course they can. This is what the engineering representation looks like of service mapping, something that I do a lot with several hospitals in the US and love to do more in Mexico, perhaps under the National Academy of Medicine, on teaching service mapping to doctors and nurses so that we introduce it into the hospital system. We've done a lot of work learning from other industries, again, on how to be better team players. Notice human factors is at the top, and process and teamwork and threat and error management, and of course, the culture of change that I've talked about. This is a key book that you might enjoy about this. My team for 20 years has been working on developing team training for doctors and nurses. We borrowed from Patrick Lencioni's work at Harvard that teams can only work well, again, the care human side of it, if they have trust. If they're not afraid to speak up, psychological safety, if they're not afraid to commit, and if they're accountable to their actions, that's when you get the best of results. Here's some data from the UK showing that when staff, Enrica, don't feel committed, don't feel engaged, more patients die. This is across 18 different studies in the UK. Here's another one from the UK, multiple studies showing that when staff do not feel engaged in the mission of the organization, There's more inpatient mortality independent of other considerations. There is a price to pay for delivering unsafe care to patients, but also not respecting the staff who don't feel supported, don't feel entrusted, don't feel kindness. In short, the violence of the work that takes a toll of the staff as well as to the patients. Here's some work that we did in Chicago, Julie's team, that Len knows well, and Enrique, in which we showed that a culture tool can predict surgical mortality. So we can rank order hospitals in Chicago based on the culture. Irrespective of any other aspects of metrics, is the culture is a marker for better outcomes or worse outcomes in some of the best hospitals in North America. A few words on team training. Another thing we don't really teach in medical school, so this is number 4, I'm counting, of the factors why, the question that Len was asked, why doesn't it change? We don't teach teamwork. We did this work 20 years ago, the knowledge, skills, and attitudes of teamwork in the ICU, in the recovery room, in the wards, in the operating room, all based on 3 things: trust, shared mental models, and communication. This is part of what has become known as team steps. At the heart of it is the culture change. No surprise, this work is the most measured team training tool in the world. It's been able to show an 18% reduction in mortality. There is nothing out there, anything even remotely close. So Enrique and Raul, I'd love to introduce Team Steps to Mexico with you in a Mexican version, adapting it to the unique challenges of the private and public and all the rest. But this is a powerful technology of sorts that now is close to 20 years experience. It's being used in about 2,000 hospitals around the world, remarkably effective in dealing with these types of issues. I want to wrap up. A final model is high reliability models. This is Carl Weick's work, a giant of organizational culture and change from Michigan, who argues that if you want to have high reliability healthcare, you have to teach this. Again, this is not taught in schools of medicine, nursing, or management as it relates to healthcare. These 5 elements are essential for delivering it. This is what it looks like in our model. So we've applied this in 5 major hospitals in the US. Clear principles of business, clear practices for the CFO, the CMO, the CIO, and the CNO. The principles are leadership, culture, and improvement. This all comes from Deming, through Shohart, through all the work that I've discussed earlier, all coming together under a high reliability model. This is some work that we published now 12 years ago. We interviewed 100 senior executives from around the world, and these were the practices that they said are needed for high reliability outcomes. Again, problem number 5, we do not select executives for these skills. We do not hold them to account on these measures. This is not how regulators in Mexico or the US measure hospitals for performance. This is another key element why things don't get better. This is the British model for it from the Health Foundation. Learning systems. How do we use things from the system to engage differently, to hold differently, to measure differently? This is a model, I think, that we could introduce to Mexico as well, a model that needs to be customized and aligned locally. This is a tool that we use in North America for measuring culture in hospitals. I'd love to talk to Mexican clinicians online on how we could pilot this in Mexico. This is asked once a week, in which we get a clear sense of the culture on units. Notice, Len, that the most important thing there is the patient experience. All the other elements are part of this wheel of culture. We try to create this just culture. What does that mean in practice? That when clinicians try to do the right thing, we don't punish them. We support them, we engage them, we coach them. It's rare that you need to fire or discipline a clinician, and that's because they've been reckless. And we define recklessness by conscious disregard of risk. This is a rare thing in healthcare. Often, that's not the behavior that we're seeing. Here's some work that we've just published from Japan, a major hospital in Tokyo. We looked at 5 years of patient complaints, Len, and we looked at how often do patients and families complain versus how often do they send in notices of gratification and appreciation. And again, another element that we need to use more tactically and strategically to change practices in hospitals. So, 2 final thoughts on self-harm. We know that Staff burnout in Mexico is a big problem. I was just there about 5 weeks ago. 44% of nurses want to quit. About half of physicians say they don't like their work. So it's important to remember this idea on how do we think about how all the things that are happening, in this case in Mexico, but it parallels North America, on how these things are influencing staff access, too much work per staff member, exhaustion. This is the translation to the surgical where I live. These 8 elements, we've been using this wheel in Mexico, the physical toll, emotional toll, spiritual toll. When we interviewed residents in Durango recently, we found out that less than 5% of the residents go to church. Less than 5% of them have exercise. Less than 5% of them feel safe financially. Less than 5% of them sleep well when they're at home. Many of them do not have stable relationships. How do you expect these people to grow and mature and be leaders in their community, delivering safe, trusted, kind care, if that's the case? So this is a picture I took when I was recently in Africa, and these elephants are helping each other. We need to help each other change the healthcare system. That means patients and staff and management working together to transform this outcome. It means a safety management system. It means taught in medical school, held to account by regulators and administrators, and knowing the best and applying the best of manufacturing knowledge from Deming and Shohart and many, many other giants that transformed industry, including in Mexico, which is a powerhouse in manufacturing, but is rarely looked at as a model for changing healthcare. It means the fearless organization. Again, this great book by Amy Edmondson. How do we help clinicians be fearless, to speak up and to tell the truth and not be afraid when they see aberrant behavior? It means using education, but education is the weakest tool to change outcomes. The most effective is redesign, better barriers, better mitigations. That's where the National Academy of Medicine can help out. That's where CONAMED and COFEPRIS can help out. While education and training is important, it's the least effective when it's by itself. It must be coupled with real systems engineering and changes in the models to engage and change. And finally, of course, at the end of the day, I learned this from Don Berwick, culture always trumps everything else. So unless we think about changing the culture, which means we need social scientists in medical school, in residencies, in regulators, to understand the need to change the culture in order to engage it. This is the paper we published, again, 20 years ago, in which we talked about the fact that the system will only change if we focus on the harmony and trust amongst the human actors. So the care human actors, if we modified that term, aligning with the amazing work that Enrique is leading on here, this idea of changing the way we socialize providers, the way we support them, the way we engage them, and the way we reward them in their organizational model. Final word, this is an organization I'm part of that focuses on helping children with heart disease. I highly encourage you to get involved with me or others if you'd like to participate. This is particularly focused on improving the outcomes of children with heart disease in Mexico and other low and middle income countries. So I'm going to end there. These are some books that we've published on this work. I'd be delighted to answer any questions by WhatsApp or by email. Thank you again, Enrique, for this kind invitation. And I look forward to comments and questions. Thank you.
Thank you very much, Paul. Tenemos espacio para una pregunta. Ceci, por favor, we have one question.
Hi, I am Cecilia Garcia. In knowing which is the effect of kindness as a construct in burnout in caregivers. And the other is that if you have studies about psychosocial support to caregivers and what is the effect of these programs in healthcare and in outcomes.
So my question, I don't know if Raul is also in the room, Enrique, I can't see anybody but you, but can together advance these ideas. And given the challenges in Durango 2 years ago, we had another example of a terrible death of a young girl from plastic surgery in Durango a few months ago. These examples of system-based human factors change management. How does the National Academy of Medicine help to lead on this, and what can we do to help them move this forward?
Paul, we will going to use a very basic technology because the sophisticated one is not working. So aquí tengo en el teléfono al doctor Paul Barach. So, could you make the question directly?
Okay. Can he hear it from the telephone?
Not.
Yes? Okay, thank you. I'm Dr. Cecilia Garcia, and I'm very interested in burnout. And you were talking about burnout in Mexico, that it's very, very high. And my question is there the influence of being kind and all this construct of kindness in burnout in the caregiver? And the other question is if you have social support programs for caregivers, and what is the influence of having these programs in outcomes, patients' outcomes?
Thanks for the question. So hopefully that was, all right, that's okay. So we know very clearly that lack of kindness, lack of trust leads to burnout and bad outcomes. We know this for a fact. We also know that burnout has never been worse than in the last 5 years. Careful studies done in North America, as well as in Europe, as well as in other places, suggest that we have an existential crisis. Our staff isn't happy. Our staff is harming itself. Our staff is consuming more drugs, more alcohol, more marijuana, more cocaine. We know that we have an extraordinary problem, and I connect all these things together. And so we need to support these efforts for burnout reduction, and we need to support those people who do so. Clearly, some people are better than others in helping others. So just like some people are better than others in being pastors and priests, equally, some people are better than others in being empathetic towards their colleagues. We can do this. This is possible, but it has to be a priority. The solution is not to open up more nursing and medical schools. This is not the solution. We are hemorrhaging more and more staff from more and more schools. In some programs around the world, 30 to 50% of the graduates want to quit medicine and nursing. It's dramatic. The answer is not more schools. The answer is dealing with the people in the system who are passionate about caring for others, who came there for the right reasons, and for a variety of reasons have lost and have soured on those intentions. This must be a national priority. It must be manifested in reward system. It must be manifested in regulatory system. And it has to be part of how we train people. I was not taught one word about burnout when I was in medical school, nor in residency for that matter. There is more conversation now, but it's not a structural thing that is part of all levels of training and support, and it's certainly not connected to long-term viability of staff as they mature and grow in the system. So we have much work to do there to take the research and implement it in systems and practice. I hope I answered that question.
Thank you very much, Paul. I'm sorry we'll have to stop here. Of course, there are many questions, among them the one that you made about the role of the Academy, which I would leave to our president to answer, and perhaps in a future conversation with you. You both know each other very well, so we'll have a chance to discuss the role of the National Academy of Medicine in these matters. So thank you again, Paul. We'll see you soon.